Welcome, everyone. We're so excited to have you all here today for our CAP webinar on chronic pain management. I'm very excited to introduce you to Dr. David Becker. He's a clinical professor in the Department of Pediatrics and the Osher Center for Integrative Medicine at the University of California, San Francisco. He's a pediatrician who specializes in integrative medicine, behavioral health, and chronic pain conditions. Dr. Becker was a primary care physician at UCSF for 15 years before fully transitioning to integrative medicine and behavioral health. He completed his medical degree, a Master of Public Health, and residency in pediatrics at University of North Carolina at Chapel Hill. He also completed a fellowship in integrative medicine at University of Arizona's Andrew Weil Center for Integrative Medicine and a master's degree in clinical psychology at the Wright Institute. He has expertise in integrative medicine, mind-body strategies, chronic pain management, and psychology. And we're really excited to hear from you today. During the talk, please put questions in the Q&A or chat, and we'll get answer those as best we can at the end.
All right, hi everybody. I give them a moment to pull up my slides. Okay, thanks so much, Lauren, for the introduction and for the opportunity to talk with you all. I'm really grateful to be able to talk to my people, because I was in primary care for 15 years and I miss it actually a bunch of the time. I love being right across the street from the Mount Zion clinic here at UCSF, where I can at least go see some of my colleagues and friends from time to time. So with that in mind, I have been spending a good chunk of the last 10 years or so working with kids with a range of complex medical issues from the perspective of an integrative medicine pediatrician, in addition to my hat as a marriage and family therapist, and the expertise I've gained in pain and pain management over the years. So I was hoping to talk a little bit about today about an updated model about understanding pain and pain signaling, particularly as it applies to unexplained pain, or pain that is, and we often talk about chronic pain, and understanding that signaling in order to inform how do we talk about it? How do we go about approaching helping the kids that we work with in understanding what's going on inside for themselves, and in thinking about ways to guide their recovery through that process. You got the background piece. I do intend to talk about some approaches off-label, as I believe it's actually challenging to talk a lot about approaches with pain management where things are entirely on label. I have no financial relationships to disclose related to this. I have plenty of gratitude for a lot of people I've learned from over the years and the people I continue to get to work with currently, whether it's in my pain clinic or people I've learned from in terms of understanding pain, to the folks I've trained in mind-body strategies with, in addition to the training and consultation I've gotten in my therapy practice. To frame this discussion, I thought I would just bring up 3 case examples that you all are probably really familiar with, the kind of things that show up in the office and often are challenging, not only diagnostically, but also in terms of our capacity about thinking about how to help. So the first is an example of a 12-year-old who returns to your office about 3 weeks after being seen for a sprained ankle. Initial films were negative, repeat films for Salter 1 are negative. She's complaining of persistent pain and still feels like she needs her crutches. Her exam is essentially unremarkable, except for some more sensitivity to manipulation than appears to be explained by the appearance and by imaging. Sam's a 15-year-old with a history of IBD that's currently in remission on maintenance medications, who presents with a quote-unquote flare of abdominal symptoms. That could be a whole host of things, whether it is bloating, pain, diarrhea, constipation, crampiness. Recent GI follow-up, including scopes and serologies, were all reassuring. Marlies, a 16-year-old who returns to your office after consultation with rheumatology, GI, and neurology evaluations for chronic pain, joint pain, fatigue, recurrent abdominal pain, and headaches. Evaluations to date have been reassuring, and the family's feeling really frustrated. I imagine these are all pretty familiar for most of you. So to cut to the chase, this is the beginning slide and also the end slide. A big component about this is managing expectations, not only for our patients, but for ourselves. These individuals take time. It means planning multiple visits. It means taking the time when you can to go through the aspects that we're going to talk about for the rest of this talk. A good thing to keep in mind is just to assume that they think that you think it's all in their head. And if we start from that standpoint, it will help facilitate the conversation that you have. It is important to communicate at some point, but not at the beginning, that there's no quick fix. Engagement with the entire family is really crucial, and we'll see why in a little bit too. Progress with chronic pain conditions, when there is unexplained pain, is generally slower than it's expected, and functional recovery happens before pain improves. There's a challenging concepts and things to deal with for a lot of kids, but they're important to get from the beginning. Another piece that's important is holding the hope that it actually can get better, and then demedicalizing. So if we look at the broad picture of pain and pain management, this slide is taken from my colleague Stefan Friedrichsdorf, who's our new soon-to-be division of pediatric pain, palliative, and integrative medicine. And if you haven't heard him speak yet, I really recommend attending any of his talks about pain and pain management. He does a wonderful job of really, especially around so much of the medication approaches around pain. This is a slide that is a cumulative representation of 2 talks worth of material. And in this talk, I'm not going to be touching on analgesics or the adjuvants or the opioids or the regional anesthesia component. That's out of my scope. We're going to talk a little bit about, well, the medications aren't, but the regional anesthesia is. We're going to talk about a variety of other things, and mostly how to set our own mindset and framing, and how to communicate about what's happening with somebody with unexplained pain, which can feel daunting, to say the least, and challenging about where do you even begin in this process. So you're all familiar with our typical breakdown of types of pain: nociceptive pain resulting from peripheral nerve injury or damage, somatic pain from muscles and joints, visceral pain from internal organs, or neuropathic pain due to dysfunction of the somatosensory system. That is a breakdown of kind of anatomic locations about where pain signals come from, but it doesn't really explain pain so much. Chronic pain in particular can come from a whole variety of sources, but is mostly about the central processing of pain rather than a particular location where it's coming from. So how do we define that? And this concept of, well, what the heck is pain anyway? The International Society for, now I'm blanking on the whole name of it, published in Pain in 2020, came up with a most recent definition of pain: an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. It's a little wordy, but it captures the idea that pain is an experience that isn't necessarily directly related to whatever our peripheral nerve endings are telling us. Another way of summing it up is, in other words, it's a warning signal. It's basically a protection signal. So to put this in another frame, when we think about sensory information that we're exposed to, whatever kind of degree we might think it might be, whether it's really light touch or a simple pinch or a small bump or something that we routinely think of as really severe that can cause severe pain, all of that input, all of that sensory input of whatever may be happening is filtered through a whole variety of components centrally in our nervous system that impact what that experience is going to be like. There are our baseline physiologic factors. What's the current state of sympathetic arousal at the moment of whatever that sensory input is? How much ongoing inflammation is present in the body or in the brain? What is our level of sleep or fatigue in addition to physical conditioning? There's psychological components to this, whether it is our underlying propensity towards anxiety or depression, our adverse childhood experiences, our capacity for resilience, past illness experiences, a whole set of social dynamics that influence the meaning of pain. How is it that the meaning of certain events are held in a given family, in a given community, or with peers or friends, whatever situation you're in addition to really broader notions of meaning of illness, of our components of our own sense of health and wellness that influence the body's resilience or capacity to tolerate and deal with symptoms. All of this influences whatever the experience of pain is in any given moment. So then this is another way of rephrasing this, all pain being a subjective sensory and cognitive and emotional experience influenced by all of these factors. And the sensory input is ascribed meaning by our limbic and cortical brain regions. And all patient-specific responses are moderated by the degree of fears or hopes, expectations, or memories. All things for which we don't really have a pill. So what do you do? How do you help, especially when the system gets out of whack? So before we get there now, we're going to talk a little bit more about kind of to use Lorimer Moseley's terms, a more modern view of pain and pain signaling. So we're going to represent that last diagram a little bit differently. So Lorimer Moseley he started as a physical therapist in Australia and has become an international leader in understanding pain and pain mechanisms and pain recovery. He and his team conducted large studies with individuals dealing with chronic pain to distill down 4 key factors of chronic pain and pain recovery, which they ultimately came down with as pain itself is a protection mechanism. The pain protects us and it promotes healing. Persistent pain overprotects us and prevents recovery. Many, many factors actually influence pain, which also means there are many ways to reduce pain and gradually recover. So when is it that pain actually becomes chronic or persistent? How do we know that? There's the definition of this has been around for a long time. From one of the early pain texts from the 1950s, well, it's when pain persists past the normal time of healing, whatever that actually means. When it's disproportionate to the nociceptive input, one could consider that as persistent, or in this case, out of proportion to whatever the inciting event is. When it becomes a maladaptive response, or in other words, when it becomes overprotective, or when it no longer supports recovery or health. So there are a whole host of diagnosable chronic conditions that fall under a rubric of thinking about pain that has become disproportionate to underlying mechanisms as far as they can be understood. And this whole set of conditions, from chronic regional pain syndrome to chronic fatigue syndrome to fibromyalgia, many functional abdominal pain syndromes like IBS, chronic daily headache. These conditions have often, from the pain perspective, has been considered as representative of pain that is unexplained or out of proportion to what can be determined. Now, does that mean that there may be mechanisms we don't understand yet? Potentially. However, in the absence of that, when the objective information we have can't explain it, how do we go about trying to help? Now, the conditions on the opposite side of the screen, illness, anxiety disorder, somatic symptom disorder, and functional neurologic symptom disorder, are in the DSM-5, and the older names of them are listed. These conditions can present with pain as a predominant feature. And when that is the case, this model of understanding pain and explaining pain can often be really helpful. These are just a few questions that can be kept either in the back of your own mind, or questions you can actually dialogue with patients about how to understand when is it the pain has become chronic or persistent. Has the underlying injury had adequate time to heal? Has any underlying condition been shown to be in remission? And does the pain seem to be disproportionate to what we can determine? So I'm going to shift then and talk a little bit about this evolution about understanding pain and pain signaling from a more biologic perspective. The history of this you all are also probably familiar with and remember seeing diagrams like Rene Descartes from the early 1600s, who was the first one to localize the concept of pain as a signal traveling in the body from the periphery to the brain. However, his idea of this was basically like a string attached to a bell. And his assumption is that any individual, if you got your toe next to a fire, is going to experience exactly the same thing. And it's a really simple mechanism. In the 1960s, our beloved gate control theory of pain was first introduced with a better understanding about the anatomy of peripheral sensory fibers and how information is transmitted through the dorsal horn up to the brain. For many years, this has not been updated. And it's in more recent view of a similar idea of the gate control theory has been updated by the presence of down-regulatory signaling that can come from the central nervous system. And here that is represented in the purple and the red. Information or signaling that comes from the brain that can influence or modulate the signaling that's happening at the dorsal horn. That's probably what most of you all have been familiar with seeing so far in terms of our understanding of pain. What's been discovered more recently is that this network is extraordinarily complex. The image that just added was also from the dorsal horn and shows all of the connections and all of the different signaling that goes on, even at that level. Not only the various types of inhibitory or excitatory signaling that's coming from the central nervous system, but also all the microglia and how they influence all this communication and signaling. It's incredibly complex. And that's just the dorsal horn. Centrally, in the brain, Lorimer and his team, and if you're looking for fantastic discussion about how all the pain processing happens, I can't recommend his books more. Explain Pain, the original one, just Explain Pain, came out a number of years ago, and Explain Pain Supercharged, if it's not out yet, will be out soon. So in this, he describes not only what's happening at the dorsal horn, but also centrally. And this image, as impossible as it is to read, is representative of essentially what I was talking about in my own version of the screen, about all the different factors that influence what pain actually means. So the little bubble here it says I have pain in my toe. In the image you can't see off the screen down the bottom is the image of a toe with a little pin on it. And the signal's coming up to the dorsal horn and up to the brain. Now, I know you can't see a lot of these, but many of them have to do with inflammation, for example, with cortisol and adrenaline levels, with previous experiences and outcomes related to pain, with what's happening in the skin, what's the position of the body, what movement is going on. And here he's talking about beliefs and belief systems and how all of this is interconnected in the neural networks. Yeah, I have a magnified view. This is his representation of all of the components that are influencing this final experience of I have pain in my toe. And what I'm going to talk about a little bit is how do you translate that to helping somebody who's just in your office and doesn't want to stand on their foot 3 weeks after they sprained it because they say it hurts too much? What do you do with that? This is just to say that these two are essential similar representations, this conceptually and the other diagrammatically, about all of the influences about what is that experience of pain. So to give you a little bit of background about data, about how is it that we understand these things are components about pain and pain experiences, this is an analysis of the National Survey of Children's Health from 2016 and 17 of nearly 50,000 kids, 6 to 17, and parent-reported adverse childhood experiences, and looking at the association with chronic pain. And as you can see in the table at the side, there is a dose-dependent association of the odds of reporting chronic pain and the number of adverse childhood experiences that are reported by parents. So we know this influences pain as a reported experience. This is a fascinating brain imaging study that helped to understand that the brain encodes information about pain experiencing in different regions. So we're so used to the somatosensory cortex being the location of pain. What this shows is that there are two different regions in the brain that encode the perception of the pain itself, perceiving it as a pain signal, and the degree of suffering or affective component that's related to that pain. They're encoded in different regions of the brain, and therefore influenced by different inputs and aspects of brain function. Just a highlighted screen of the last one that he's talking about each of these various points and how they contribute to pain. Okay, so let's shift to conceptualizing this in a way that might be helpful that you could use for some patients. This also comes from Lorimer Moseley, and it's a conceptualization about how is it that the body and the brain's experience of pain shifts from one where we have a normal tolerance and a normal experience of pain, and one in where we become unusually sensitive or unusually perceptive about pain experience. So before whatever issues are happening or problems that are going on, when our body's functioning normally, we have a certain capacity to face major challenges. In this case, just represented by the mountain and climbing a mountain and all of the physical exertion that goes into that. The more you push yourself, eventually you're going to get pain experiences that are signals to protect you, to say, hey, if you go much further, you might really injure yourself. And we all have this experience in various ways, and we usually less consciously tune into them to dial down whatever we're doing. But that area between where we're perceiving pain as a protection signal and where the tissue injury actually happens is what he calls the safety buffer. That's a region where you can live and push things a little bit without actually causing injury. What happens is that all the various inputs we were talking about, the various influences that affect how we experience pain, or in this case, represented as quote unquote problems, will shift this whole buffer system so that the degree of exertion that's required to trigger a protection response is much less. You have a new safety buffer in which you are less able to do than what you were to do before. And this is all due to central sensitization or hypersensitivity of processing of pain signals, and has really very little to do with peripheral input to pain or the degree of damage that's happening. To give you another example to think about this, if you imagine an experiment where there is a set standard degree of sensory input. In this case, just imagine squeezing of a finger. Imagine putting a certain degree of pressure that could have some degree of pain. Let's say, imagine some certain component of pain and degree of injury. And if we hold steady the degree of that pressure, but you change how it's applied, the pain experience will vary. Imagine, so here, and this is, again, taken a bit from Lorimer's work. If you were to imagine these three different scenarios where you yourself are the one squeezing your finger to a certain amount, or it's a good friend of yours who's sitting there squeezing your finger to a certain amount, or somebody you have no idea who they are that's squeezing that finger to a certain amount, which one's going to cause the most pain? even though the injury might be the same. Generally speaking, if you're doing it yourself, you're not going to feel as much pain. If it's a good friend, it might be a little bit more, might not, but if it's a stranger, it's a different experience. Well, why? It's purely based on fear. When you don't know who's in control of what's really going to happen, the pain experience changes. And that's what happens in an experiment with this, is that the reported pain will be different depending on those different circumstances. To give you another example from a study that's demonstrating how is it that a pain experience happens that's different from the somatic input. This is a population of adults, in this case, who had neck pain to a certain degree. And they were all asked to do this study where they were using virtual reality and in a controlled environment. And in the virtual reality, what they discovered was that what they can manipulate is when you move your head a certain degree, they can move the visual image more or less than the degree you're actually moving your neck. So what would happen would be that if in the experiment, individuals with pain were asked to move their head and they moved their head, let's say all the way around to the right, but the visual screen actually only changed a little bit, their reported pain was less than just moving their neck to the right without the visual reality or the virtual reality. And in reverse, if they were shown a visual image and actually physically moved their neck only a touch, but the image moved a whole lot more, they reported more pain. So the pain experience is influenced certainly by the physical activity and the peripheral sensory input, but also by visual input, independent or separate from the physical input. So where does all that leave us in terms of how do we talk about this? Where do we go with helping people understand this in language that's going to be helpful for kids? And this slide is just, again, to review all the craziness of what the potential options are for approaching this. But I want to shift us a little bit away from our more ingrained medicalizing framework to thinking about the tools that are usually in our toolbox, which are around medications, to think about using our own voice and using how we talk about pain to help people shift their own mindsets and understanding so that they can do the things they need to recover. And the key components to this, this is my view about thinking about what's really helpful for these folks, is in the process of helping them understand chronic pain, certain components will really help them with this. One is validation. Most people, when they're experiencing pain that's out of proportion to what seems to be going on, will usually need some validation. They need to know that we get it, that we hear that what's going on is really rough, what they're going through. They need to be appreciated and not dismissed, whether directly or indirectly, given the message that, oh, it's not really real, or you shouldn't be feeling this. That is an example of an invalidating comment. So education is another piece. We're going to talk about each of these in a little bit more detail. Validation. This is the part that's about being certain that they know, that you know what their experience is, how bad it's been, and whether anyone will listen to them yet. My referral bias here is that for much of the time that I see case examples like the ones I started with, is that they've already been down the road of seeing 2 or 3 or 4 subspecialists. And despite the best intentions and the best communication with many, many well-meaning providers, they frequently end up with a feeling that nobody believes them. So whether that's true or not is less material than that's actually how they're feeling. So anticipate that when you've got people coming into your office that have been in 3, 4, 5 times in pain, they're going to start to feel more defensive. And this is when it's really important to take a step back and start to be curious about what their experience is. Start to be more reflective in the listening so that you name back what the experience is, even if it feels illogical, even if it doesn't really make sense. So each time that foot touches the floor, it's really excruciating, isn't it? I mean, it really is just intolerable. Just to imagine even putting that foot on the floor, boy, that's tough. It must be really hard. In that process, looking for the nonverbal communications that will help guide you to whether or not you're in a sense, that you've actually, that they really believe or understand what you're talking, that you get it. You know, that communication could be they are complaining less, they're not talking about it as much, they're listening or hearing you a little bit more, as a positive indication that they're feeling understood. And on the other hand, looking away, giving a groan, all the various nonverbal communication skills, we want to attune to those, because if we're getting signals that they don't feel like we get it, that means we got to go back to step one again until we do, because it's going to be hard to help reframe what this experience is until they feel heard. They need to have this aspect of validation in order to feel like we're communicating understanding about what their experience is. It's one of the hard parts with this is that oftentimes when we go about validating experiences that don't conform to our own sense of reality, it feels like we're actually agreeing with them. And it doesn't necessarily need to imply that. You don't have to agree with what their belief is, only that to validate the fact that the experience must be really tough. How you go about it, we were just talking a little bit about this. Allow for the degree of genuine curiosity and connection that comes up with you in your own way. And if you can, avoid the faking it part, because most of the time these kids are pretty sensitive to that already, and they'll pick it up pretty quickly. We want to name sometimes the things that they haven't talked about yet, but they'll help you gather the whole picture. And help them normalize this. Now, a wonderful discussion of this, by the way, if you haven't seen it, Dr. Forwood's CAP webinar on anxiety, I think it was last July, is beautiful discussion of anxiety and talks a lot about these conceptualizations. And if we have time for it, I will talk a little bit later about the overlap between anxiety and chronic pain. So to build on this bit about language and how we talk, I want to talk a little bit about what we know about the importance of language. Dan Cohen is a developmental pediatrician in Minneapolis who's been one of my favorite teachers of clinical hypnosis for years, and I get the privilege of teaching with him now. But I still love to go back and look at the important aspects of being sure that we think about how we talk, because it's more powerful than we usually recognize. And if Dan Cohen isn't enough of an authoritative figure, maybe Dumbledore is. I mean, it's how we go about communicating with folks matters. We know this from plenty of research. Placebo, we're plenty familiar with. Most of you are already familiar with the idea of nocebo effects. We're very, we know that how we talk about certain aspects of things can lead towards experiences or expectations of experiences that wouldn't have otherwise occurred. So the research that's referred to at the end of this was looking at patients in an inpatient setting who were on, and there's two different studies, one around anxiety and one around pain. And if we look at the pain one, this is an experience of people who were on an IV opioid and randomized to discontinuation of that opioid. And on discontinuation, they were either told the medication was stopped or not told that it was stopped. And as you might expect, those individuals who were told, okay, the medication's off now, began reporting return of pain significantly sooner than the individuals who were not told that the medication was stopped. Now, is that a nocebo in the usual way we think about it? Like, oh, you might experience this or this side effect. No, but it's the obverse of that period. When you say something that implies something's going to change, it's more likely to happen that way. How does this apply to us? This is a study in pain from 2005 that looked at the language used in a clinical circumstance where minor procedures are being performed. This could be vaccinations, it could be blood draws, it could be a host of different things. It's not necessarily the image on the side here. And what they did is they tracked the words that were used, the procedure itself, and then facial expressions or objective outside objective views about pain and pain experience. And what they found is that the pain experience was significantly increased with a variety of language, such as, you shouldn't feel anything sharp. This will hurt a bit, there'll be a little poke, little sting here again. Are you uncomfortable? This isn't ideal, I know. If you're not comfortable, you let me know. Okay, it's gonna be really hot. It'll feel like a bee sting. Let us know if you feel any pain. Each one of these phrases, and probably in one version or another in years past, I know I have used, and I'm doing everything I can not to use these so much anymore, because what happens is that despite the intention of these being information, of these being helping people with a heads up about what's going to happen, what we do by using these phrases and these words is we instill the possibility for these happening when otherwise they might not. So as an example, and this is a little bit about acute pain and acute pain issues, which is a whole separate talk. But when I'm talking to clinic nurses about giving vaccines and pain experiences, and we talk a little bit about this language, I usually ask is like, well, have you had an experience where you've given a vaccine to somebody and they tell you, oh, I didn't feel a thing? And invariably, we all have had that experience where I didn't feel it. So then I'd ask, well, then why would you give them the language that something else is going to happen when you don't really know? So there's more to that discussion with a different talk, because that's more about acute pain and about changing language. The important piece is that context matters. A whole host of things will influence what an experience is like. The temperature of the room, what the feeling of the paper is on the table, how people are talking or not talking to you. A whole host of things will influence all of that sensory input for pain experience. Okay, so that's a bit about validation. Let's talk a little bit more about education. How do we, and this really is kind of the meat of what I want to get to, which is how do we talk about pain with kids? How do we help reframe in new language what they're experiencing into a way that helps them shift their understanding of what's going on, that lays the groundwork for actual recovery? So reframing pain is a lot about the psychoeducation, about helping people understand what's pain about, what's it for, why do we get it, and why is it that I'm feeling what I'm feeling? You're telling me you understand and you get it that I'm having this much pain, but why am I having this much pain and nobody's helping me? So imagine that's the position you're in. What are you going to go through for this discussion? So I am going to model in a way how I go about this. This is going to be a little bit longer dialogue, so bear with me for a minute, but this is going to include probably more features of pain psychoeducation than I would in every single case. But I want to run through all the various analogies or metaphors that I use, and hopefully bits and pieces of this you can distill from. Now, this has been an accumulation of ways of talking about this over the years, and many of my colleagues use very similar ones or slightly different ones. But this is one way of explaining what it is that's going on with pain. So usually it's talking about this. If you imagine I'm in a clinical encounter with, let's say it's an adolescent who has some degree of disproportionate pain. We're going to eventually get to the point after I spent plenty of time on the history and plenty of time with my rapport that I know that they know that I get it, that what's going on is real. Once I know that, then I can start going into re-education about pain. If I'm not at that point at the end of a 45-minute visit, I'm not going to start talking about pain and pain education yet. I need to be sure that I'm actually on the same page with what's going on with them and that they know that I get it. Then we can embark into this. All right, so at some point I will ask them, why do we have pain? What's pain for? And most of the time when we talk about this, you get a blank look. So it's about talking about, well, pain has a purpose. We need it, actually. It's a protection for us. It's actually very, very helpful. So you imagine, I'm sure you've had your own version of this, but if you're at home and somebody's just gotten finished using the stove and you start to get your hand too close to it, you're going to get a signal from that hand that says, hey, be careful. If you go any further, you keep that hand there any longer, you're going to have a problem. That's a protection signal. And all pain serves some degree of protection for us so we don't end up injuring ourselves. That's why we need it. So it's really, really important. So how is it then that, how does this whole sensory system work? So if you're telling me that that's a protection signal and it's actually just a warning, the information coming from that hand near the stove, the only information coming from the nerves from that hand is warning, pay attention. There's no other information coming from there. All the rest of it is encoded up here. So I usually will shift into thinking to helping them understand how the whole sensory system is available to perceive information in any given moment. So while you're sitting there in that chair, you may not notice it until I speak to it, but I'm sure that once I mention what's the sensation of those feet on the floor, what's the sensation of that mask around your ear, what's the sensation of this, that, or the other, you become immediately aware of it. That's because the brain has the capacity to be aware of any of these in any given moment. However, if we were actually aware of everything all at once, it would be overwhelming. So we have a system that filters it. So when, so I'll give you an example. This is with the kids. I'll give you an example about what happens with me when I'm in my wood workshop and I have my hand out and that hammer comes down and it misses the nail and it hits my finger. My reaction is, ah, crap, I did it again. They usually get that. So I'm like, okay, so what just happened? So what happened is I got a really big warning signal from that finger. It said, pay attention. It was a little late, but it was a warning signal, pay attention. That information goes from my finger to my spinal column. It starts to communicate with other nerves in the spinal column and goes up to the brain. And when it gets up to the brain, it hits this place called the thalamus at the beginning. That is the filter. That is the filter that is actually filtering out most of the sensations for you sitting in that chair right now that you're only aware of unless your brain tells it to be aware of. Once it goes to the thalamus, it branches off to many, many different places in the brain. There's a place in the brain where it tells it, hey, that's happening in your finger. But that's the only information there. It's just saying that warning is coming from your finger. There's another place in the brain that is encoding the type of experience, sharp, burning, throbbing. It's giving it a quality or sense of what type of pain it is. That information is communicating with the thinking part of your brain, or the prefrontal cortex, which is the part that's saying, I did it again, holding my finger. It's also communicating with what we call the limbic system of the brain, or all the emotional centers of the brain. And that part of the brain is giving it more information, which is the crap part. That's the emotional piece. All of that communication in the brain somehow or other comes together into one conscious poof where it gives you the whole experience at once, but it's all related to all these different inputs. You don't really know that in the moment, but that's what you experience, the whole collection of it. So how does this apply to you? So, well, let's think about how when this system actually is not working well, when it's not working the way it's supposed to, what's going on? Usually this is where we can get into a variety of metaphors and analogies, and I will give them either like a phantom limb experience about phantom limb pain. Most of the time I'll ask them if they ever heard about phantom limb symptoms. Usually these days, kids and teens haven't, but parents usually have, and that helps because parents get it, and so they trust their parents. So phantom limb experience is when, let's say I've lost a limb, let's say I've lost my arm. And what happens is when I lose my arm, this part of the brain that's used to picking up any sensory information it wants at any time no longer has any information coming from this hand anymore. It doesn't know what to tell me is going on there, and it doesn't like a vacuum. So essentially what happens is it goes back in its memory folders, it picks a file that says, poof, here you go, you are feeling movement. which is most likely what most people feel, at least initially. It may also pick other files. It might pick cramping. It might pick stinging. It might pick itching. It might pick a whole different variety of sensations that brain is telling you is happening in a hand that no longer exists. So a brilliant neurologist from, I believe, San Diego years ago came up with a treatment plan for this called mirror box therapy. And what happens is that if you imagine, I actually have a picture of this up here. If you imagine, and I'm talking with kids, imagine a mirror sitting in front of you at a table, and I put in front of this mirror, I put the stump on this one hand, like the girl in the picture, although it's a real hand, and my other hand next to it, and I move it around, and I look in the mirror, I see a mirror image. I can see that, hey, that's my hand. Now, my conscious brain in that moment is saying, yeah, it's my other hand. I get it. However, there's also the less conscious signal that is going to my visual cortex directly from my eyes back to this place that's giving me this experience. It's to some degree bypassing that thinking part of the brain and saying, hey, there's your hand and it's moving and it's okay. And it turns out if you do this over and over and over and over again, you down-regulate that central sensitivity, that central signal, that central processing that's giving you information that's no longer helping you. So there's an example of helping. So I would tell kids, I'm like, all right, how does this apply to you? It applies in the sense that it helps us understand that the brain can give us a very real perception of a signal that's no longer related to what's actually happening in the body. That's a validating experience for most kids dealing with chronic pain. It's helping them to understand that it's possible that their brain can give them information that really isn't related to this. And it helps inform one of these other analogies, which is hurt, not harm, which is that you can have experiences of pain that are entirely real, that are no longer connected to actual harm happening in the body, or perhaps not in the same degree. Like the example with the inflammatory bowel disorder. I'll give another example for explaining this for kids. I usually ask them, have you ever had paper cuts before? Or to give them another example, splinters. And I ask them, well, which one's worse? And usually it's paper cuts. I'm like, yeah, I know. It's like, it's just bizarre, right? It's this, it looks like it's nothing and yet it stings like crazy. Then I'll say, have you ever had an experience where, and I'll ask the parents this at the same time, you have a piece of paper, glide right over that finger and you get the sensation right away. It's like, ah, man, did it again. And then you look at your finger and you're like, ah, I didn't get cut. Well, what happened? Because you had a very real experience of everything, right? The thought, the experience, the expectation, even the sensation of pain. But as soon as your brain got new information that actually it was okay, it let it go. It released it because it didn't need it anymore. It was no longer protective. It was overprotective. This is often most helpful for kids who are dealing with localized amplified pain syndromes. For example, the case example of the kid with the sprained ankle who's still using the crutches and is very wary about doing much more, and the skin's really sensitive, helps them to understand that it's quite possible you get signals that feel very real, but now are out of proportion to what's going on there. And what it means is it's a little bit like how a fire station alarm could be. The fire station alarm is another analogy. This one is where I usually help them understand, like if you are at home, you're baking cookies, you make some cookies and you go off and do something else with your friends and you completely forget you left the oven on and it starts to smoke and now you've got a fire, you call the fire station. How do they know to get up and get in the engine and come to your house? And go through the process of helping them. The alarm goes off, right? An alarm. They get a warning signal. Get up, get in the engine, stop watching TV, come to the house, put out the fire. When they go back to the engine, the station, is the alarm still on? No, they don't need it anymore. It served its purpose. They've put out the fire, you don't need it anymore. So all of this is a way of helping introduce the potential for these kids to help understand that there can be pain signaling that's no longer protective, it's overprotective. It's actually getting in the way of their recovery and not helping them, which may just feel like we're just giving them a whole bunch of language and not really giving them a whole lot of tools. And sometimes it's a little frustrating, but this is the next step in this process, which is to communicate that I know this can get better. There's no doubt in my mind that what you're experiencing can improve. And note my language. I'm not telling them it's going to go away. I'm not telling it's going to be completely solved. I know it can get better. I do know it's going to take time. And there's a host of approaches that from this stage on, the exact tool matters less than getting engaged in a process. Because while physical therapy and pain psychoeducation are the two primary effective ways about dealing with amplified pain or hyperalgesia or allodynia, there are many other tools that can be helpful. You want to name as many positive coping skills and tools that they already have and get into a description about the next steps for physical therapy. This is a way of framing this. There are quite a few more slides, unfortunately, that I would have loved to get through for this, but with 8 minutes left, I want to quickly run through to see if there's a highlight of one or two, but then I want to move on to at least answer a couple of questions. I recognize that it can at times feel frustrating to hear about a whole talk that's about reframing a problem and about the language without a whole lot of concrete tools. But suffice to say that this skipping over the part about validation and about reframing and educating the pain and going straight to you need to do this, 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 and this, and give them a list of things is frequently a setup for delayed recovery or failure, because they're still not feeling understood or feeling heard, and they still have a conceptualization about what's going on with them that leaves them prone to medicalizing the problem, wanting to see another subspecialist, wanting more tests, wanting to figure out what else is going on. There's lots of ways in which we each can develop the capacity to talk about mind-body strategies and tools. How we talk about them can matter. I wish we had time to get into meditation and what it is and isn't, and how you talk about mind-body tools, and about how it is that the mind can't stop focusing on things. I'm going to skip over this. This is a study about pain centers across North America, and just representative of how many different types of tools are pulled on for helping kids. There's a list of a whole variety of other interventions. But I am going to open this up. At the end of the slides that you all have, there's a whole host of references and resources. Laura Mosley's book, Explain Pain, is phenomenal, both for us as practitioners and for patients and families. There's now better literature out there about chronic pain that you can find. And then in terms of the best book, I think that is a guide for both parents and practitioners, Lonnie Zeltzer's book, Pain in Children and Young Adults, really gets into a lot of the details about this, about conceptualizing pain and pain recovery. It's a fantastic book, in addition to some of these other resources. Okay, with that, I am happy to take questions.
Thank you so much. That was just incredibly informative. There were a couple different questions about kind of what language you do recommend when talking about like before a vaccine. Any suggestions of what to say, either if there's no prompting or if the kid asks, will it hurt?
Right. Great. My fast answer to this is go to the whole thing. The Meg Foundation for Pain. Just put it in the chat. So full disclosure, I'm on the board for this nonprofit organization, but the whole mission of this organization is to provide tools for parents, kids, and providers. There's now a whole tool set for providers about how is it that you help kids and families plan for procedures. How do you help them develop their own plan? And the approach for this is to plan ahead, to think about, because as much of this around kids and vaccines is about control and about feeling like they've got a sense of control and about that they have tools that can help them, in addition to feeling like they've got somebody who's interested in their view about how they want this to happen. This is a hard one it would have been a hard one for me to swallow if I was still in private practice, but this is a hard one, I think, for many practitioners to swallow, is that kids do not need to be held down and shouldn't be held down for any procedures. There are plenty of tools and ways to help them through the process. The reason you'd want to avoid holding kids down is that it is, in a certain proportion of them, traumatizing enough that it informs the rest of their experiences with the medical system in general and creates more problems down the road. So that's a longer answer that you wanted, but you'll get a lot more information at the Meg Foundation for Pain.
And
Laura, do you want me to look through the chat, or do you want to read some?
I can read. We have another one that asks for chronic pain. Do you feel that it should be managed in multidisciplinary type setting, or can it be done in primary care?
It can absolutely be done in primary care. And my hope is that this at least starts the process of giving you some language and tools to shift the progression of chronic pain. The first case example I gave about the 12-year-old with the ankle sprain comes directly from a case who actually presented to me in pain clinic, wheeled in a wheelchair, laying completely flat, unwilling to allow anybody to come anywhere near touching any of her legs, of refusing to sit up because of pain. And it all started with a minor ankle sprain that progressed over a period of months, up the leg, to the opposite leg, up the stomach, to the whole body. It didn't need to get to that point. The hard part is that in many circumstances, the most well-meaning providers aren't aware of how pain signaling can go awry. And when we continue to medicalize a problem, we may continue to play into a degree of anxiety or worry or catastrophizing or anticipation of pain that perpetuates or even expands a problem. So yes, it can be done in primary care setting. There's no doubt whatsoever. There's lots of tools that can be really helpful. However, there are also plenty of times when it just feels like it's beyond the capacity. I know time is a major limiter because our system doesn't give you the time. And that makes it more challenging to actually develop and then implement a lot of these tools. Anything else?
Yes, there was one more asking about if there's relationships between chronic pain and OCD.
I'm sorry, could you repeat that?
Yeah, they were wondering if you've noticed relationships between obsessive compulsive disorder and chronic pain.
Okay, yes. The way I usually think about this is that individuals who have a propensity to experience anxiety in one of its many forms are more tend to have a tendency to experience amplified pain more so than individuals who don't. We don't really know exactly why, but we do know that chronic pain experiences increase the likelihood of mood disorders, depression, anxiety, and the existence of anxiety or depression increases the pain's sensory system. So the two of them influence each other, but they're not a direct cause, and there's not a linear cause of one or the other. So there's an analogy around anxiety, which is thinking of the brain's network like a sticky mesh. So if our thoughts constantly come through us throughout the day, but for those of us who deal with the persistence of more anxious thoughts, it's like they get kind of stuck in that mesh and they won't let us go and they don't just move off to the other. Well, that analogy works also for pain signaling, where you have a pain experience that normally would come and like, oh, that was weird, I just stepped funny, and then you keep walking. But for people who have a really tight mesh network here around experiences, it gets stuck and they can't stop thinking about it. So that's a broader overview about thinking about the relationship of anxiety and unexplained or chronic pain experiences. OCD in particular can have slightly different features because the pain experience or the illness itself can be part of the obsessive blanket of obsessive thoughts themselves. And I'm sure there's more information on this in some of the other talks from CAP, but the treatment approaches for OCD versus general anxiety, while they're similar, can be a little bit different, and some require higher medication doses. But pain can be an experience, and pain experiences can be amplified when individuals have underlying anxiety or OCD. I wish we had more time to get into more.
Thank you so much. We really appreciate you being here today.
Happy to.
A couple requests. Would you be willing to for us to share your slides?
Of course, yeah.
Thank you. I think that's, we're all out of time for today. Thank you so much. And next, we have an upcoming special session on Friday, 3/18 from 12 to 1:30 on Therapy 101 for pediatricians. And then next month on Thursday, the April 14th, we'll have a webinar on ADHD. So we hope to see you guys all there.